Namaskar, viewers. So, in today's health question series, a very basic discussion we are going to do. As of now, we have spoken with the specialists and experts from various ailment background. But how it starts to begin with, and how do, as an individual, we can identify the symptoms and whom to approach in the beginning. Because as we are always saying that we do not know if there is a pain in the abdomen, does it mean kidney or does it mean some sort of a gastric trouble? If there is a headache, is it really a migraine or something I not done last night? I did not sleep properly. So we do not understand the details of it. So the first refuge or the destination we have is a general physician. And I thought let's speak to the doctor who can give us little wisdom on this part. So for this program, I invited Dr. Aarthi, who is from Hyderabad and a general physician consultant. So let me welcome her. Suswagatam, doctor.
Yeah. Thank you, Ms. Ketaki. Thank you for having me in this program. General medicine, internal medicine, all these things, and now we call super specialists, subspecialists. Now we have specialists for a small muscle in the eye. There's specialists to do the plastic surgery of the eye. The era is changing so much that we are specializing and subspecializing into smaller, finer details. The orthopedic has gone into hand surgeon, spine surgeon, like that. So each person. So, but then when it comes to patients, how do they differentiate? What do they do? Is it confusing? What is, like you said, where do we start or begin with? So, as a general medicine, see, first of all, let's take this the term, no, the physician or general physician.
Mm,
This is very commonly used term.
mm,
So, usually a person with an MBBS degree is also called a physician. Okay, any
mm,
doctor for that matter is a physician.
mm,
Okay, when we coin a person who has done specialization, that means post MBBS, if they have done a specialization, say MD or a DNB degree into in general medicine. General medicine is nothing but a huge ocean of medicine. It's a huge ocean of medicine from where after you finish general medicine specialization, your MD or DNB, you do subspecialization. That means after you finish medicine, you choose cardiology, neurology, or nephrology based on the specialty. So general medicine or internal medicine, okay, both are interchangeably used, whether it is general medicine. And a person who's practicing this is called a physician, is a consultant physician or a general physician, you can take it. So general physician is used by even an MBBS holder, which is also correct. So they can be your first point of contact as well. So now coming to when do patients approach us? So anything which we don't cut anyone. So what we do is we hear their symptoms and we diagnose based on the symptoms, symptomatology basically. So and then we redirect them. So if needed, we redirect them. If there is some intervention which is required by a super specialist, it is we refer to them. But at a general medicine level, lot can be treated, and if correctly navigated, they can go into the right direction. So a role of general physician is to bring and also because a lot of doctors, patient sees a lot of doctors. He has a cardiac issue, he has a nephrology issue,
mm,
he has an underlying some surgical issues. So he sees multiple doctors. But as a physician, I'll be a single point of contact where I try to bring everything together for a patient, right? He's on multiple medications from multiple sides. So what we do as a physician is try to simplify that.
yeah.
We deal with lot of geriatric issues, mostly patients with diabetes, hypertension, thyroid related issues, and any geriatric issues, and of course the whole lot of common cold, cough, and the fevers and infectious diseases what we
Great.
deal with.
Okay,
Yeah.
so I was right when I said the first point of contact is the physician. Doctor, what happens now? Most of the time, we are very ignorant, and we are a kind of in the name of layman, we tend to deny many things. So I had tried to categorize the discomfort into around five types. I said some kind of allergic thing that you said, the cough, cold, and some other things. Eye related thing, it can be anything. Then the genetic ones, which are coming through some sort of hereditary reasons. Then I said the acute and serious ones, the one which you said needs some sort of a specialist. And then I said crucial ones, where is very difficult kind of a disorder or disease. And there are some which are like non-curable, which needs a maintenance kind of support. Now, what I want to understand is, at least at the primary level, as a patient or as a caregiver or as a family, how do I categorize this before approaching the physician?
See, usually, basically, you have to go by the symptoms. First and foremost. I'm not very sure where this categorization comes from, but I think from
Just
your
mine.
point of view, you try to
Yes, a layman categorization.
yeah, based on the patients you see around, you
Yes,
tend to sort of.
yes, yes.
Of which I think first I'll take off the genetic part, because genetic is something. Genetic is a very broad term.
Mm,
So from your point of view, I think it is something like diabetes, hypertension, cholesterol related. You're talking about that,
correct.
if that is there, because genetic has many things
Hmm,
in that.
hmm.
So in general,
Even
patients.
they say heart-related things also come genetic.
Correct.
Uh,
So let's first rule out that. So now what has happened, whether it is diabetes, hypertension, or dyslipidemias, that means high cholesterol, either high LDL cholesterol or high triglycerides, and all these are sort of runs in the families. We say it's hereditary. If your parents have it, you can get it. So of course these are, and patients, especially with young CADs, that
mm,
means if your father has got an heart attack at age of 50, then of course you're at a risk, probably even a decade earlier. So especially a young cardiac disease is a severe risk factor. That means if your parents have it, then you can get. If
yes,
one of your parent has it also, you can get. So
yes,
some kind of kidney diseases, say for example polycystic kidney disease, that happens genetically. That is, it's an autosomal dominant disease, so it can happen within the family. So if your parents or maternal uncles or paternal uncles, aunts are having some sort of the cardiac disease, or sometimes even anemia, some types of anemias like
ah,
thalassemias,
mm,
all these things they can present, they can run the family. So one is recording a good family history will tell you whether you're going to get this or not,
okay.
and whether your children can get affected or not. Some diseases, specifically autosomal dominant, recessive. So based on the disease, we'll be able to categorize. Having said that, even if there is no risk factors, like if your parents have been completely healthy, no diabetes, still the children can get diabetes at a
Mm,
young age.
mm,
That is because of the lifestyle changes. We are seeing that happen.
mm, mm,
So genetically, these are the things we watch out for. So as a lay person, like because this show is going to be watched by a
yes,
lot of people
yes,
who want to try to understand.
yes,
One point I can make for them is that if you have a family history of diabetes, hypertension, or a heart related problem, it is always pertinent to get yourself checked as well. So at least do health checks once a year. Now we have a lot of preventive
mm,
health
mm,
packages which are done,
mm,
which in my view are very useful, very useful, especially to tackle the risk factors that we're
yeah,
seeing.
early
Because
diagnose.
yes, early diagnosis.
Mm,
And especially because having high BP and high diabetes, high sugar levels will not have any symptoms. Patients always deny. And
mm,
I don't have any symptoms, madam. How can I get? Yes, that is the catch. That's why we are doing the test. Because having, unless the sugars are going very high or your BP is very high, till then you may not be having any symptoms. So all these are incidentally recorded. That means when you walk into the chamber, most of the times BP is recorded in a hospital. When you come for some cold or cough, then we
true,
see their high BP. So
true, true.
yes, so genetically, if you are prone, you're at a high risk. Even otherwise, anybody above 30-35, I feel they should be regularly getting checked. So that's for the genetic part.
Yeah.
Now coming to allergies, right? So again, allergies is like a broad sort of
Mm, mm,
classification. So
mm,
commonly, what happens is we see seasonal allergies, which
mm,
happen seasonal. I think
yeah,
Bangalore, we have seen that happen.
true. Change
Pollen
in
allergy,
weather gives a lot of
change in
problem.
weather
Yeah.
creates, some people develop sort of asthma, breathing difficulty, lot of
Running nose,
sneezes,
sneezing.
running nose, sneezes. All these are
Yes.
common allergies which cause some sort of eye irritation. These are common flus and common allergies which are there. which can be tackled at your physician level. They can give you some antihistamines and exposure to that. And if you're an asthmatic, you may require a, we may increase your dose of inhalers, and those things can be done. Now, another in the same spectrum, there's some
Yeah.
serious allergies in terms of, for the medications they can develop allergies,
Mm.
or they can develop anaphylaxis. That means it is life threatening, so you could be allergic to some
True.
medication.
True. Mm.
So before you start on some medications, you should be careful. And if you have a family history of allergy, that also should be taken into consideration. So one point for the layman here is, at any point, taking some medicine or taking some food or something which has led to allergy. Allergy is different from side effects.
Yes.
I give you a medicine, you develop some gastritis, loose stools, that is not allergy. So a lot of people think, doctor, I'm allergic to these medicines. So actually it's not allergy. What you have developed is side effect of the medicine, which happens with any medicine you take. There are some
Correct.
sort of nausea, vomiting, some
Yes.
side effects.
Yes.
That is not equal to allergy. So,
Yes.
but allergy could come in terms of having breathing difficulty, having rashes all over the body, their BP dropping, causing issues. So, if you have experienced any of this while taking medicines, make a note of that medicines,
Mm.
because at a later date, you should not be using them.
Mm.
When you meet your next doctor, you should be able to tell them that I have an allergy to
Yes.
that. So, that is one useful point, because in my prescription, my first note at the right corner would be what are their other medical issues, or if they have any allergies. So that should be noted in, every this thing. So if the doctor has not asked you, you make it a point to tell them about your allergies. Okay. Next, Ketaki, we spoke acute versus chronic.
Acute process. Yes. Yes.
Yes. So this is something which we are, as a physician, we see both spectrums quite, or like in a typical OPD of
Mm.
say
Mm.
20 patients,
Mm.
at least 5 or 6 will be acute. Most of them will tend to be chronic. Okay, so how do we differentiate this? Acute is when they're coming with fever, cough, some urinary infection, respiratory infection, some mild pains here and there, some muscle aches, and those are usually acute, wherein patient probably will come with their symptoms, we diagnose what the problem is and treat them temporarily. They may not have a chronic problem leading to that. So say if I have malaria, I treat it, it gets better.
Mm.
That way. So it is the sort of some infection, say if it is COVID, we treat it. COVID, of course, is acute and long COVID. We have all. So most of the viral infections, fevers, what we see come under an acute category. And when we say who are these chronic patients we see and who need to come to us regularly, even if they're doing well,
Mm-hmm.
this is a nice platform for me to tell them that they should be on regular follow-ups. That is, anybody with diabetes,
Mm.
hypertension, heart related issues, thyroid diseases, or if they have underlying autoimmune conditions, there are multiple other conditions which require chronic care. That means we may need to check them once in 3 months, at least once in 6 months. These are the patients. And if they have an underlying some heart related issues, which can be tackled, so once in 3 months. So these are the patients whom we look at the medication, see how they're adjusted, and we adjust these medicines. So lot of our practice in general medicine will be adjusting their medications, lot of it. So although like I don't know, I had written a long time ago a blog on this. So how we've cared for a patient for almost 10 years, 10, 12 years, how we have cared for the patient. So although one time one procedure is done, but then the remaining chronic care that they require for years. So that is a chronic sort of care. So in terms, even if the patient is doing well,
Mm-hmm.
coming back for regular checkups and follow-ups will help us, understand how they're doing, their
Right.
requirements, and all those things.
Correct. Doctor,
Mm.
in this context, okay, sorry, do you want to say
Yeah,
something?
yeah, no. Continue. Yeah.
In this context, you just said one term, that is atonement. And I really want you to educate people on that particular part, because I've heard from some people that no medicine will work for me, or
Which one? Which is that?
the autoimmune diseases.
Autoimmune diseases. Okay.
Okay. So I want people to understand what is it. Second thing, Is it so common term that every now and then people are using it? And
Mhm.
third thing, are they beyond repair? So these are the misconceptions I want to understand from you.
Right. So I'll tell you in simpler terms. So we all have heard of COVID infection. That's the
Yes,
best example we can
yes,
take. So what happens is, if say for example I got COVID, right? So the virus antigen gets into my body,
yes,
okay,
yes.
and I develop antibodies for that. So my body is trying to react and
Fight it.
fight that particular antigen, which is an outside foreign thing. No, it's a foreign thing for me. It's not there in my body. So it's a foreign thing, and I'm trying to fight those antigen which is developed in my body with the antibodies.
Correct.
Okay. So now what happens in autoimmune, right? So what is happening here is because of the COVID antigen, I have developed an immunity. My
Mm,
antibodies are acting and it's developed into an immunity.
mm,
So, but what happens is in autoimmunity, there is no foreign risk for me. There
yes.
is no antigen which is there.
Mm-hmm.
But my body is abnormally acting. It's abnormally producing the antibodies. These are called autoimmune antibodies.
I see.
Typically, the tests are done as ANA is called anti-nuclear antibodies. So, what it does is my body, without any outside reason, is producing some abnormal immune material. These are the antibodies it is developing.
Mm,
Now, what it thinks is, now the immunity is there. Now, what it's trying to do is it's trying to fight it.
mm,
Okay. But
mm,
there's no foreign particle that it has
mm,
to
mm,
fight.
mm,
So
mm.
it fights its own body.
Own body. Oh.
So it starts affecting our own immune cells, our own body organs. It starts affecting. So
Mm,
it perceives the our own body as threat and it starts
mm,
fighting it. So that is the whole thing about autoimmune diseases, where your body is thinking that there is some threat to it, and the abnormal antibodies are fighting the normal cells which are there in the body. Okay.
they're actually killing the healthy cells, it means.
Yeah, they're killing the cells, their own cells. They're killing their own well performing cells. So, that
Mm,
is the whole premise of autoimmune diseases now. So, autoimmune diseases typically we see in women. There
mm,
are some diseases which affect men,
mm.
but typically in, say, young and middle aged women is what we see.
I see.
Anywhere between, say, 20 to 40, 45, typically we suspect autoimmune diseases. Now,
Any
when do
reason
we
for that, doctor?
that's how those diseases are. There's no particular reason.
Okay,
Most of
I
them
see.
don't have any reason. Like I said, it's again in itself a big branch in itself. So the specialists who deal with autoimmune disease are called rheumatologists.
Yes,
They are the rheumatologists who treat.
yes.
So now what happens, what typically symptoms we see in these autoimmune diseases are they can develop joint pains,
Mm.
small joints, especially, small joints of the
Uh-huh.
hands and
Mm,
feet, or
mm,
multiple joint pains like rheumatoid.
mm.
And they can develop skin rashes, abnormal menses, frequent abortions,
I see.
menstrual issues. They can have weight loss, even mouth ulcers.
Mm,
Mouth ulcers they can have frequently. All these are some basic symptoms of. And typically, what happens in autoimmune disease, it affects multiple organs of the body. It's usually very rare to see that it affects only one organ. So, based on what symptoms you primarily have, we categorize.
mm,
So, even if we do tests, there are tests for, say some 30, 40 disorders can be tested.
mm.
We do autoimmune antibody panel and we can check it. But many a times, all of them can come negative as well,
I
or
see.
it can be undifferentiated. That means it is
Okay.
difficult to diagnose. We cannot put it into one particular syndrome. There are
Category.
multiple syndromes in
Mm,
that. So obviously, so diagnosis gets delayed
mm,
because patients are not aware.
mm,
They think that this is something simple, ongoing.
mm,
So by the time they even come to a physician, it's good 1, 2 years. They would have lost that 1, 2 years of not being able to diagnose, because
mm, mm, mm.
the clinical suspicion should be there. Only if your
Correct.
clinical suspicion is there, you think of autoimmune conditions,
Absolutely.
right? So the awareness is less. Thankfully now the awareness is more.
Mm,
Patients are getting tested.
yes,
More tests are available. Like I said, we can do an autoimmune profile
yes,
that comes. The
yes,
report comes in two to
yes,
three days. We get the report. So then, first point is diagnosing it.
mm,
The second point is the treatment. Like you said, no, whether it is unresolved, whether it cannot get treated.
yes.
Unlike, it's not like that. There are a lot of There's a lot of treatment options. So obviously what we are doing now, I told you there are abnormal antibodies which are there. Now these abnormal antibodies need to be killed,
Mm.
right?
Mm.
So we give immunosuppressants to
Okay.
decrease the immunity. So when we are giving immunosuppressants, along with the abnormal cells, even normal cells will get affected. So there are going to be side effects of treatment. Okay, as much as so, in this case, this is one condition in autoimmune conditions where steroids are life saving. That
Mm-hmm.
means you're alive because you're taking steroids at this
Mm.
point, because they're acting as other immunosuppressants. They're life saving. That means even though they have multitude of side effects,
Yes.
but still they are life saving for this particular
For this
condition.
particular
So
case. Okay.
so even though there are side effects which we know how to monitor, how to get them back, how what to do to prevent them from those side effects, but these medications will be required.
Mm.
Of course, from a patient point of view, it is a difficult. Some are very serious disorders. Chronic fatigue will
Yes.
be there, and they need to continue treatment. Because they're on treatment, there are going to be problems because of the treatment, and the disease itself might progress and all that. But having said that, I think last a decade or so, we've seen good treatment
Treatments.
for even
Okay.
autoimmune conditions. There are a lot of newer biological, lesser side effect drugs which are available. Patients are doing very well. So it's not like a very bad disease to have. Of course, any chronic disease is a
Absolutely. Yes.
bad enough,
Yes.
but then there is treatment available, and by right diagnosis, reaching the right person, you can definitely
Treated.
get diagnosed.
Okay.
Yes.
So, doctor, now just now you mentioned, and I had this in the list also. Like I have heard from some people again during the COVID, like some antibiotics or some heavy dosages of medicines are not effective for them for whatever reason you just now mentioned. So, what I want to understand is antibiotics is a very common thing in our life nowadays. Without even consulting a doctor, we ourselves have become our own doctor, and we know if I take one, two, three, I will be out in 3 days. So, on the counter, we are purchasing the antibiotics and taking it. My worry is, um, the kind of discomfort or the side effects that you said it gives, it's nowhere documented. And patients should do at their level, one. Second thing, somewhere I feel even the doctor should also give that caution to the patient, because, side effects are sometimes more dangerous than the disease. And prolonged usage of antibiotics is another area of discussion. So I want you to give more understanding on this part, like how crucial to follow the dosage schedule, and also particular antibiotics or any particular regime that we by default and on the fly follow, how dangerous it is.
Yes, yes, this is a very important point, and I think I'm glad we had this in our questionnaire. That is, now currently we know that there is influenza virus going on.
Yes,
You know,
yes,
the current H3N2 sort of, it's a sort of an epidemic. We are seeing everybody falling sick,
yes.
and already patients who come to me are already taking azithromycin, they're taking augmentin, they're over the counter, they have taken the medication.
Okay.
So but clearly knowing it's a viral disease.
Mm.
Okay, viral disease requires nothing but rest, and lot of tender loving care, rest, love, care, and lot of fluids to drink, and some paracetamol to go with it. Even today I write the same prescription. Patients get disheartened, madam, what is this, you're writing only this? But I say, this is what
This
you
is the
need to do
treatment.
for 4 days or 5 days. If your
Yes.
fever is persisting beyond fourth day or fifth day, then you come back. Then let me tell you what to do. But always educate the patients, because they are worried. They're getting fever of 103, 104, so they are worried. So you educate them. So any viral illness lasts for about 3 to 5 days, and what you need to do in the interim, and what are the red flag signs which you need to look for. Say, for example, you have some other urine burning
Mm.
sensation, or you're not passing enough urine, you're becoming giddy, there is other symptoms which are developing. You basically educate them.
Yes.
If it is cough, then the cough is expectorant, bringing out a lot of sputum, which is not viral in nature. No, in those terms we start. So basically you reassure the patient. You tell them that this is the course. This is expected complication. Like for dengue, doesn't need any antibiotics, but we see patients on injections, directly on injections for that. So So at multiple levels, like I said, no, we everything is available over the counter, and we tend to take it. So one thing is, you're talking about side effects, but I'm even more worried about antibiotic resistance that we are
Yes,
seeing.
yes,
So even at an OPD level, we already see multi-drug resistant organism. Okay, at an OPD level, which has been going on, which has been so severe infections. So the pipeline of antibiotics is very limited.
mm,
So I can only go from one end to the other end. Beyond that, I don't have any antibiotics to give. It's almost like a pre-antibiotic era. In 1945, when Alexander Fleming discovered the first antibiotic,
mm,
the patient was in sepsis. He was in sepsis. He no BP recording and all that. So Fleming gave penicillin at that time, and the patient got better. So now patient is on 10 antibiotics. He's in the same condition as Fleming, found him. Like, the BP is not required. Patient is in severe sepsis. He's on 10 antibiotics, which we have given. So that is the danger of antibiotic resistance. The more you take without any logic, and the proper dosage is not given, they feel better, so they stop the
yes,
medicine. So you're making giving a
even more
resistance
high risk. Yes,
antibiotic, high resistance comes up. And of course the side effects, so something seizure prone, some can cause low platelets, some can cause loose stools, vomiting, maybe some medicines are not
yes,
suiting you. So always antibiotics need to be prescribed by the doctor. If he feels it's deemed necessary, then we should take it. As much as they're life saving, because in sepsis they are life saving, we have nothing else, we give antibiotics. But at
yes,
the same time, for a viral infection, taking an antibiotic, those things needs to be avoided. So from a doctor point of view, patient should be reassured, told what symptoms to be watched out for,
mm,
when you feel it is bacterial, when you need to come back to the hospital if the danger signs are in, like for a patient is diabetic or they have high risk
mm,
factors.
yes,
In them, the risk of bacterial infections are more. So we need to give them a proper dose of antibiotics for
correct.
harm. Ideally, all the cultures should be done: blood cultures, urine cultures. It will help us look at the epidemics of the community, right? And this community, what is the organism I'm seeing? And dosage can be decided based on that. So over the counter taking antibiotics should be strictly banned, but God alone knows when we can come up with such a strict rules. Yeah.
Difference, yes. Okay, so before we wind up, doctor, for today, what is the closing remark that you want to give?
So I think the closing remark would be that general physician can help you, navigate what is the problem.
Mm,
You don't imagine your problems yourself.
mm.
Don't Google yourself. It's good to Google, find out the right information. We are okay with that, but
Not treating
don't,
yourself.
yeah, don't do it yourself. Let a good physician guide you on what to be done. And we've spoken a lot in length about autoimmune diseases, about antibiotics not to be taken over the counter. Take the help of your physician or your family doctor who can help you with
Yes.
these issues. Yeah.
All right, great. So we will stop for today. But as I said, we have some more important points to be discussed and which are equally vital. So I look forward to having another session with you. For today,
Thank,
thank you very much and please take
thank you.
care.
Thank you so much.